Okay, so last presentation of the day. Very pleased to see how many people are still here. So that's very exciting. Sometimes you never know if you're the last speaker, if you're talking to an empty room. So this is great, and I appreciate it. So what we're going to do is spend the next hour or so. I don't know that it'll take quite that long, but we'll go through a focused review of just the sections B, C, H, I, J, K, and O. Wanted to just at least provide a little bit of review and sort of respond to some of those questions that have been coming in through the help desks and just clarify things and talk a little bit about some of the changes you'll see. Although they're not significant, they're more related to clarifying definitions and providing additional coding scenarios in the manual for you, so it's all good news. Acronyms for the presentation. And before I do the overview, just to be consistent, I have a third child. So 3 presentations, 3 children, sorry, so you have to hear about all 3. So my third child is my youngest, obviously, and she is 24 years old, and she is actually, as of this week, a third-year medical student. And yes. So I wanted to share that there is hope in the future for medicine, because not only because she's just a great kid, and I think she's going to be great, but because of the way she's being trained. She goes to the University of Connecticut School of Medicine, and they no longer do lectured medical programming. It's all team-based learning. And what they're charged to do is to work as teams to develop diagnoses and educate each other, because the reality is that no one works as a solo anymore in healthcare. And they're constantly being told that healthcare is a team sport and that you need to learn to get along with each other, to hear from each other, to listen. And they've spent a significant amount of time sending these kids out to hospitals already, where they're spending larger sums of time with all of our specialties. So she has spent quite a bit of time with OTs, with PTs, pharmacists, lab techs, all the different people that will be part of the team that she's working on. And she said they regularly remind them that they are an equal player on the team, that although they lead in some ways, they are not the lead in all ways. So I think it's pretty exciting to hear how that goes. So I'll keep you posted if I get to come back. Okay, so we're going to do a quick overview and identify and explain the intent of each of the sections that we talked about. We're going to do section B, which is the hearing, speech, and vision. C, cognitive patterns. We affectionately call that the BIMS section at our place. Section H, bowel and bladder, the active diagnoses, which is section I. Section J, which is health conditions, which also includes falls for those of you who do this regularly. Section K, which is swallowing and nutritional status. And then section O, special treatments, procedures, and talks about the influenza vaccine. And we're going to discuss some coding instructions and required information and practice some things. And before I go further talking about the flu, I just wanted to give a shout out to this gentleman here who single-handedly spearheads flu vaccines. It sounds like at his facility. And so kudos to you. We need more people like you. So good for you. Okay, so objectives. Today we're going to demonstrate an understanding of the data elements. Hopefully by the end of the session you'll be able to do that. You'll be able to state the intent of these same sections and be able to apply some coding instructions accurately too. So we'll start with section B, which is the hearing, speech, and vision section. And section B items are assessed on admission. They're only done on admission. It's BB0700, which is the expression of ideas and wants, and BB0800, which is the understanding of verbal and nonverbal. It's important to document the patient's ability to understand and communicate. We do this on admission because it steers so much of how we treat the patient moving forward, right? I mean, we have to know how much they understand, whether they can hear us, so that we can adjust our treatment plans to meet the needs of the patient. Whether they understand and hear us is important, whether it's in actual language or in writing, sign language, or gestures, or any combination of these. The facility where I work, we have a very high percentage of stroke and brain injury. If you combine those two categories of patients, we run somewhere over 64%. So just with those two categories of patients, so we're very interested in this information. So the BBO 700 coding instructions, this looks familiar, this screenshot, I'm sure, for all you PPS coordinators out there. So we want to enter the code that best reflects the patient's ability to express ideas and wants. Some of the coding tips, which aren't really a big surprise, but we want to make sure we're all using the same definition of sort of complex messages. And for the purposes of this item, complex messages include things like, can the patient talk to you about their medications? Can they understand if you do some medication instruction? Can they report back to you what maybe some of their medications were at home and how they went about obtaining their medication? Some discharge planning things. If you're going to go in and talk to your patient, will they understand what a visiting nurse is going to do and understand, who may be obtaining meals for them and participate in those kind of discussions and understanding. And then any caregiver issues as well, whether it be a spouse caring for them or a professional. Are they able to really participate in those kinds of conversations and understand? For BBO 800, the coding instructions, we want to enter the code that best reflects the patient's ability to understand the content that we're talking about using his or her preferred method of communication. And this is where there is a slight change, and it is on that change table that I encourage you to take a look at. And that is that nonverbal content can be considered for this item. So, for a patient who maybe had some aphasia or something prior to admission and maybe uses some sort of an assistive device or assistive technology for communication, that would be included in here. One of the people that kind of quickly comes to mind, imagine Stephen Hawking's. If he didn't have assistive technology, would we believe he would understand the information that we're talking about in the complex messaging? So there are folks out there who access and utilize assistive technology more and more, especially as technology is increasing and it's becoming more available to people. So we want to make sure we include that as well. Okay, for section C, we're going to talk a little bit about the BIMS, which is the brief interview for mental status. We're going to clarify some instructions and response options to align with the wording in the minimum data set. And again, this is reflective in that change table. So it's really clarification of instruction rather than sort of change in any of the items. And the following items were slightly updated: the C0200, the C0300, which is A through C. Again, for you PPS people, you probably know this backwards and forwards, C0400, A through C. So the BIMS, for those of you who don't do it all the time, or for those who do, it consists of really three components. The C0200 is the repetition of the three words. Temporal orientation is part of C0300, and that's orientation to year, month, and day. And then we go back on C0400 to recall those three items that we presented under C0200. And then we total the results, and that's what we receive as a summary score for the BIMS, or the BIMS final score at C0500. So we really want folks to do the BIMS. So as inclusive as you can possibly be, we would like you to attempt the BIMS as often as possible. So you want to interview any patient that was not screened out by that first item. So the interview really should not be attempted if the patient is rarely or never understood they can't respond verbally or in writing, or an interpreter is needed but not available. And if that's true, then you would skip down to C0900 and skip the BIMS. The assessment is a 3-day assessment like most of them. So the use of an interpreter, we're really hoping that you'll be able to obtain an interpreter within that time period in order to complete the BIMS whenever possible. You want to conduct the interview clearly in a private setting, right? People perform better if there's not a lot of external and distracting stuff going on. In our IRF, we still have some double rooms. I don't know if folks out there do as well. And so if the speech therapist is doing the BIMS, we put a little sign on the door that says, we don't do testing in process. Patients didn't like that because they don't like to think of this as a test. So we just say, you know, therapy in session, and we have opportunities when the other patient is maybe in the gym doing therapy. We will then have the speech therapist or the occupational therapist do the BIMS. They do also have like private offices, our speech therapists, but when you remove them and take them into this private office, we found that some of the patients think they're being tested, and then that sort of causes some anxiety for them. So we typically do it in their room in those first 3 days. You want to make sure that the patient can hear you clearly, right? Because what we know is people who can't hear us may misinterpret what we're asking and what we're saying, and so that wouldn't really give them a fair shot at responding correctly. You want to sit so that they can look at your face. Whether we realize it or not, we express ourselves oftentimes through facial expressions, and for some people that's a cue that is helpful to them. And it's usually a good idea to just give an introduction to why we're doing this, you know, something to the effect that, you know, I'm going to go through a series of questions. We find that it's really helpful to gather this information early on in your stay so that we can, you know, tailor your rehab plan to meet your personal needs. And that usually is enough for people to kind of be agreeable to it. Again, if the patient expresses concern, you know, you can, remind them that we ask this of everybody. We haven't singled them out, that we think that they have an issue or a problem or we have a concern, but that we do this for all the patients. We conduct the interview in one setting, so that's also why we put the little magnet sign on the door and shut the door, because we don't want to get started on something and then the housekeeper comes in and interrupts, well-intended, but doesn't realize something's going on, distracts the patient, or somebody else, even the physician comes in and wants to do an exam or something. You know, it really can change the outcome of the BIMS, so we found that pretty helpful. If the patient does choose not to answer a question, and this comes up, I don't know for any of you in the room that conduct it, does anybody here do the BIMS? So we have a couple, yeah. And I don't know if that kind of comes up, but sometimes every now and then people just don't want to answer for whatever reason. And if that's true, we just accept their refusal and move on to the next question. If the patient's primary method of communication is in written form, the BIMS can be done this way. This is a question that's come up a couple of different times from the help desk and in frequently asked questions. The expectation is that this probably is an unusual kind of situation that someone, you know, communicates primarily in writing, but it could come up. There is a section of Section C in the QRP training manual that talks specifically about how to administer the BIMS in writing. And so you do want to make sure that if you have a patient, because it's one of those rare occasions that you want to go back to the manual, review the instructions before you go in to do the BIMS that way. That way it gives the patient a fair shot at performing to the best of their ability. And there's also a section for guidance for completing the BIMS and alternative methods in the back of that section, as well as two supplements. One is a supplement A that really just gives a lot of nice tips on performing the BIMS. A number of different just, you know, nice to know things. And then also some written materials that you can use for those folks in writing. So they're there for reference. For C0200, that's the repetition of the 3 words. We're going to record the maximum number of words that the patient repeats back correctly on the first attempt only. So as much as we want them to do well, we have to only record the responses that they give us on the first try. The words can be recalled in any order and in any context. So for those of you guys who do the BIMS, it's blue, sock, and bed. And I can't tell you how many times the therapists at our place say, they put it in a sentence. I found my blue sock in the bed, or the blue sock is under the bed, and I don't know whether naturally your brain does that to find a way to kind of remember, but oftentimes people will answer back in a sentence, and that's fine. They gave you the 3 words. You do not score the number of repeated words on a second or third attempt. So in the section C of this manual, it does talk to you about after you've provided the 3 words, the patient responds back to you, then you do give categorical cues and ask the patient to repeat. That is, we don't record the score of those, but that's just a way for us to attempt to have the patient remember that for when we go back to the recall section. For section 0300, temporal orientation, we're going to assess the patient orientation to year, month, day of the week. And we code 0 if the patient doesn't answer. Our speech therapists and occupational therapists are the ones who do our BIMS. So if a patient is receiving speech therapy, then the speech therapist does the BIMS, and if they are not, then our occupational therapist does it. It's just our personal way of doing it. We felt that it would be easier to train a smaller number of people than to try to incorporate all the PTs, all the nurses, the social workers. So this is how we've chosen to do it. There's no direction that is required. You can choose to do it at your facility as long as the clinician is able to perform that. But what our folks tell us is they like to put the responses in the margin and then add up the score afterwards, because there's a little bit of math involved, and if you're in the middle of an interview with someone and you're kind of distracted by doing the math, you kind of lose connection with the patient, so we recommend that. And you know, the scoring is different because if I answer and I miss by 1 year, that's a certain code. If I miss by 2 years for the year, that's another response. So, and it's all clearly defined there. For recall, C0400, that's where we ask the patient to recall those 3 words again, and we record yes if they were able to remember the word, and no if they did not. We're going to ask the patient to go back to the earlier question, recall. You really want to be fairly consistent with the 5 seconds. Give them 5 seconds to recall for a spontaneous recall. And if they're unable to do that, then you provide a category cue. And a category cue is something that, you know, blue, a color, bed, a piece of furniture, sock, something you wear. Those are categorical cues. And that helps people to remember. And we allow 5 seconds after each category cueing for each missed word that is recalled. So if you start the BIMS, you know, you answer that C0100 question and you believe that you should be doing the BIMS, but after beginning the BIMS you discover that it's not working, the patient is unable to answer. Either all the responses are nonsensical or no verbal or written response, or no verbal or written response to some questions and nonsensical responses, then you would stop the interview at that point. You know, a nonsensical response is different than a response that is just not correct. So if you're asking the patient what year it is, but they give you 1978, that's not a nonsensical response. But if you ask the patient the year and they say, you know, I don't know my daughter's address, then that's not a response that's similar to what the question is. And there are great guidelines, again, in Section C. I encourage you to bring back to your staff that are doing this assessment to really focus on the instructions in this section. It's very clear, and there are great examples. If the interview is stopped prior to completion, so you start it, but then you realize I have to stop because of the nonsensical answers or whatever, You are going to code a dash in C0400A, B, and C. You're going to code 99 for your summary BIMS score, and then you're going to code yes that you should conduct the staff assessment, and that's a different assessment that we do for folks. So, and then complete the C0900. If the BIMS should have been attempted, but was not for some reason, the way you would code section C is as follows. You're going to indicate that the BIMS should have been conducted. So in C0100, you would say yes, but you'd enter a dash for the items that you did not complete. You would code a score of 99 for the summary score, and code 600, C0600 is yes, and then you would complete the C0900. I'm not sure what type of situation this would match, but there may have been some situations where a patient came in and it didn't occur, and you realize it, and so you need to move on. I can't really think of a situation where this would come up, but it's always good to have. I don't know, are there some? Okay, so people are saying yes. Okay, so that's probably why this example is now in the manual, so good. There's also a great video that you can download from YouTube. You know, you want to be fairly consistent between the people doing the assessment, so the YouTube video is helpful. We have just decided to add this as a competency for our occupational and speech therapists. We're always looking for competencies for those groups, for Joint Commission coming in and for employee appraisals. So we are adding this as a competency. We're fortunate in our institution to have a sim lab, and we usually use our sim lab for things like codes. You know, we do mock codes and we videotape it, and then we allow staff to see how they performed and you know, critique how they might have done things different. So we're going to do the same thing with the BIMS, actually. So we're going to have folks act as patients, and we're going to have the different therapists go in and perform the BIMS and set up different situations, you know, videotape it and give feedback. What we found is when we first had the sim lab, nobody wanted to go near it. Nobody wanted to be videotaped. Nobody wanted to be critiqued. But once people realize that it's really fun and the intent is really to kind of step back and learn how you can perform better, especially with codes and things like that, they really enjoy this type of training. And when you're constantly putting training forward to folks, it's kind of hard to keep it fresh and new. So we're hoping that this will make it a little fun for them and provide some entertainment too. Okay, section H is bowel and bladder. Okay, so we always want to start with the definition of bladder incontinence. For the quality measure, it is an involuntary loss of urine when there is loss of control of the evacuation of urine from the bladder, and this is regardless of whether the linens are wet or if the clothing is wet. So it's really about the loss of urine control, not where the urine goes. For section H0350, the coding item, we're going to code according to the amount and number of episodes of incontinence. I don't know if you can see the screen from back there, but there's a code 0 for always continent. There's a code 1 if you are stress incontinence only. 2 if incontinence is less than daily. 3 if you're incontinent daily. 4 if you're always incontinent. 5 if there's no urine output for those folks who are on dialysis potentially. And number 9, not applicable, and that's really for folks with an indwelling Foley catheter, which, you know, sometimes we still get patients, I don't know, do people still get admissions with people with Foleys? We do too. We usually take them out pretty early, but we still see them coming over from the main hospitals. So we do still see them. Stress incontinence was something a little new when we first started training on the quality measures. And so stress incontinence has its own code, and episodes of incontinence are just small amounts. It's not a full loss of bladder control. It's usually, you know, associated with someone who's coughing or sneezing or laughing, lifting heavy objects or exercise. This question comes up in the help desk, and we wanted to clarify, stress incontinence may be coded on the quality measures, the IRF-PAI, but does not necessarily need an ICD-10 code from a physician. So if a patient reports to you that they have stress incontinence, or if the daughter pulls you aside and says, my mother wears this little pad, and maybe if she's in the gym with the therapist, she may, lose a little control or something like that. Or if one of the CNAs comes up to you and says, I've noticed little bits of urine, and we query the patient, then you can code this stress incontinence. You don't need a ICD-10 code. For the H0350, it's a 3-day assessment period. You do need all 3 days to collect the information, right? Because we're asking, are they incontinent daily? So we need to do it all 3 days. There is no look-back period, though. So for this item, it's just the 3 days that they're with you. You're going to want to review all the documentation available to you, query all the staff. If you have, nursing assistants or patient care technicians, whatever they're referred to at your facility, clearly you want to pull those folks in. The occupational therapy folks may be the first ones in the room if they're doing ADLs with a patient, and they may be the first ones getting them up in the morning, and may find that they've been incontinent overnight. If a patient is intermittently straight-cathed, and we do a lot of that, besides our brain injury and stroke, we have a comprehensive multiple sclerosis program as part of our outpatient, and so we get a lot of MS patients as well, and many of them are intermittently straight cathing, or we're teaching that skill when they're with us. We find that they've been living at home with these bladders full, and they really should have been straight cathing. But it takes a little while sometimes, right? I don't know, for the nurses in the room, it takes a little while to figure out exactly when they should cath so that they're not, having episodes in between the straight caths. If they do have incontinence episodes between the straight caths, that's what you would code as incontinence. So you would include that as an incontinent. The patient, and this came up at the first training, I still laugh whenever I think of it because I remember the occupational therapist who came to the microphone to ask, if a patient is continent but due to behavior purposely voids on the floor, it's not an incontinent episode. And, when I first heard this, I thought, kind of looking at this gentleman here, we hadn't come across anything like this, but since that training we had a brain injury patient who we'd take the gentleman to the men's room, we knew he was continent, we would bring him back to the bed, and all our brain injury rooms have cameras. He would urinate right over the side of the bed the minute the nurse left the room, and then ring the bell. So it was a little bit of a behavior piece, and we did work it through, and it's part of that specialty. But when she first asked that question, it didn't mean anything to me, but now I know why she asked. So code according to the number of episodes of bowel incontinence is what we code for item H0400. So we went from 350, which is urine, to 400, which is bowel. And if you can see that, bowel continence is 0 is always, 1 is occasionally incontinent, 2 is frequently incontinent, 3 is always incontinent, and number 9 is not rated because they may have an ostomy. Being continent has to do with the ability to voluntarily release stool in a commode, toilet, or bedpan, or as a result of a planned bowel movement or bowel program. So this was also a question that came up in the very first training and still continues to come up. For a lot of our patients, some of you may have pretty robust spinal cord injury programs. And when you're doing bowel programs with patients, what we do is we intentionally stimulate the bowel, whether it be through DigStim or manual stimulation or suppositories or whatever, and we expect them to release the stool afterwards, and oftentimes for some of the higher level spinal cord injury patients, that's done in the bed on a chuck or pad, before we can get to a point where we're getting them up to the commode or Hoyer lifting them to something. So if the patient moves their bowels following a bowel program, then that is not considered an incontinent bowel episode. However, if 4 hours later they're working on a mat in the gym with a physical therapist who's now moving them a little bit and that creates an incontinent episode, then that would be considered an incontinent episode. The other question that's come up before is, if the patient is incontinent because they have C. diff or because we've given them more than they need of laxatives, which sometimes we overcompensate. Some of our patients come having not gone, right? I'm seeing heads nod. That's a universal thing, I think. Coming from acute care, having not moved their bowels in many, many days, and we're good at this, so we get right on it. We know the importance of this. So sometimes we may overcompensate, and for a period of time the patient may have loose stools until we can dial back and figure out what exactly they need. Regardless of the reason, the patient is considered incontinent, so you need to code it that way. So we have a practice scenario for item H0350, which is bladder. On the day she was admitted to our IRF, Mrs. H experienced one episode of large amount of urine leakage. She also reported to her nurse that she has had a small amount of urine leakage each day, and I'm adding something, during therapy, and wears a pad in her underwear. She has otherwise been continent of urine. So, how would you code, I forgot her name, Mrs. H. No, we're in section H. How would you code Mrs. H? Would you code her a 0 that she's always continent? Would you code her a 1 that she has stress incontinence only? Would you code her a 2, incontinent less than daily? Or would you code her a 3, incontinent daily? Okay, so we have some responses coming in. I realized after this practice coding scenario, might not have been the clearest, but we'll talk about that. So, okay, let's see. So the correct answer is a code of 2, incontinent less than daily. So let's go over the rationale. So the code should be 2, incontinent less than daily, because the patient was incontinent of a large amount of urine during the admission assessment period. She did experience stress incontinence only, so that doesn't count as the daily. And I probably should have said in that example that it was related. That's why I added in the exercise. So one of the things that this example, the point brings up is that you really want to go out and query the patient. You want to go out and query the staff. What were the incidents related to that small incontinent episodes? Could it have been stress incontinence? Okay, active diagnoses. So section I, there's slightly changes here. For item 1 or I-0900, peripheral vascular disease or peripheral artery disease are in one category. So they've been combined. I-2900, diabetes, includes diabetic retinopathy, nephropathy, and neuropathy. And I-7900 is none of the above. And this is a checkbox item. You can check more than one. For those of you who do this on a regular basis, you know what I'm talking about. So you could have a patient who has a checkbox for peripheral vascular disease and also has diabetes. Can we do the questions at the end just in case I cover it before we're done? Okay, thanks. So you want to code the disease that are active diagnoses, and you want to document them at the time of the admission. These are admission items. And one of the questions that's come up is, if I have a patient who has neuropathy do I check this box? And to be clear, this is, the I-2900 is diabetic neuropathy, not general neuropathy. So you would not code a neuropathy patient here, just a diabetic neuropathy patient. And a diagnosis is considered active if it has a direct relationship to the patient's current functional, cognitive status, their mood, their behavior, medical treatments, nurse monitoring, or risk for death at the time of the assessment. So it's pretty easy for diabetes. Most of our patients are coming in. Their nurses are checking their glucose. We might have them on a sliding scale insulin. So it's an active diagnosis for most part. There should be specific documentation in the medical record if you're checking this box. So we need a physician to put a code in, a physician, nurse practitioner, a physician assistant, a clinical nurse specialist, or other authorized licensed staff. So you as a staff nurse, if you see it, you got nursing verbal report and they said the patient has diabetes, we're not checking the box based on that. We need to have a diagnosis that says from a physician or a physician assistant, clinical nurse specialist. I don't know if anybody else is seeing this, but at our main hospital, we've seen a new medical designation, and it's MBBS. Has anybody seen that? It was new for us. This is the first year. And I guess it's a Bachelor of Medicine, Bachelor of Surgery, and it's Australian medical school. So we have a few interns in our hospital with that designation, and in our state, which is Connecticut, that allows them to diagnose. So that was new to us when we had to look it up because we didn't recognize what that meant. So only authorized staff, as we said, can indicate that the diagnosis is active. The patient's active diagnosis, as I said, has to be documented in the medical record. You're going to want to have specific documents in the record. It could come from a progress note, an admission history or physical, transfer of health information notes if from a physician, and acute care hospital discharge summary from a physician. Diagnosis should not be inferred by association with other conditions. So Section J, health conditions and falls. So a fall definition, and we've talked about this now since the quality reporting program has started. The definition of a fall is an unintentional change in position coming to rest on the ground, floor, or onto the next lower surface, which could be a bed, a chair, bedside mat. It may be witnessed or on occasion reported by a patient or observer, or identified when a patient is found on the floor or the ground. It is not a result of an overwhelming external force. So if one patient were to push another patient, that would not be considered a fall. An intercepted fall occurs when the patient would have fallen if he or she had not been caught, by another caregiver or person. Had not been intercepted by another person, the patient would have fallen. So it's considered an intercepted fall, but it is considered a fall. So even though you caught them, it is considered a fall. Now, CMS understands that, what we do. They understand that in a NERF setting, a lot of what our physical therapists are doing is really challenging a patient's balance in a very therapeutic way. And so when a patient is working with their physical therapist and their balance is being challenged as part of a therapeutic intervention, and I lose my balance and the therapist catches me, that would not be considered a fall because that was part of the treatment plan during that particular session. Complete the history of falls at the time of admission. So we want to know if the patient has had 2 or more falls in the past year or a fall in the past year with injury. At our facility, again, this is just us, but we have a combined department, admissions, case management, and quality, which includes the PPS folks. So we have asked our team that are out and about assessing patients, when they're reaching out to families, is to talk about the IRF level of care and explain, what it's about, talking to patients, to see if they can gather this information, and they put it on our pre-admission screen and then share that with their colleague who is the PPS coordinator. Sometimes it's hard to get in touch with the family members in the first couple of days, so whenever we get them pre-admission, we try to get as much information out of the family member as possible. For us, it's not only recording it here on the IRF-PAI, but it's important for us to know as part of our treatment plan, do we need to put this patient closer to the desk? As I mentioned, we have on our brain injury unit, we have camera rooms. We have several camera rooms on our larger unit as well. So part of our admission process is to find out about what their fall risk is. We share that with our PPS folks, but we also determine which bed we'll have them go to when they arrive. So it's a little bit of a coordinated effort. We also, because falls are important, and I'm sure you guys do too, we sort of, through transparency, have a sign right off the elevators when our last fall was, so that family members and patients can see when our last fall was. So the team is very invested in not having that number be like 1. It's only been 1 day since our last fall. So we do a safety huddle every morning at 8:25. The entire team comes to the nursing station, including housekeeping staff, the lab tech, the dietitian, anybody on the floor. Our docs and PAs do come. We run through a series of safety things. Did anything happen over the last 24 hours? We actually, which is going to be helpful for Section N, is talk about patients admitted the night before. Were there any issues with their orders? Is there anything the physician needs to attend to right away? And we've been doing that just because we didn't want to miss things, but now it's going to be helpful with the Section N. And we talk about who is a fall risk. Did anything change overnight? Do we need to make room adjustments based on that? We do that same process at change of shift on 3 to 11. They do that around 4. Clearly, there aren't as many people in attendance because there's just not as many people around. But it is an opportunity for everyone on the team to bring up concerns. Sometimes the nurse will say, well, I think Mrs. S is a fall risk down in room 11, and the PT will say, well, gee, yesterday when I was with her, she seemed good, and, is something going on? Or they'll say, her transfer is different, and Todd, the PT, may say, well, let's go down and let's do the transfer together. So the nurse and the PT kind of go down and see if there needs to be some on-the-spot training for the nurse on technique on how to transfer that particular patient. So we found it really helpful for a lot of reasons, and it has been beneficial in that it brings the team together, that we're in this together. It's a team sport, kind of like my daughter is learning, and that everybody is responsible for the safety of the patient, including like the housekeepers. They'll bring up situations that, I think you guys are leaving the wheelchair in the wrong spot, or someone took the leg rests off the patient's wheelchair and they left them this side of the room, and when I went in to clean the floor, I don't think that was a good idea. So, and they do it in a way that, everybody sort of accepts that information in a positive way and doesn't take it sort of as criticisms. So you want to indicate whether the patient has had 2 or more falls in the past year or just 1 fall if it had an injury. You're going to interview the patient if they're able to speak with you, or you could talk with family members, significant others to obtain a fall history. For some of our patients, that's why they're coming in the IRF, right? They fell, they got a subdural, maybe they fell, had a hip fracture. So we know they've had at least 1 as a result of that incident. So J1800 is where we complete at the time of the discharge, and here's where they're asking if they've had any falls since they've been with us. So if the answer is no, there's a skip pattern and we can just move on, but if the answer is yes, then we have additional questions to answer. And, I'm not sure how you guys do it, but we're pretty involved, as I said, if a patient falls. So most people know about it if a patient fell, but if you're the PPS coordinator and your job is somewhere different and you're not up on the floor as often, you can review the medical record. You should talk to the physicians, incident logs or fall logs, some people say they have, in order to keep track of that sort of stuff. So J1900 coding instructions, so you want to complete this at the time of discharge, and you want to determine the number of falls that occurred since the patient was with you, and you want to code the level of the fall, and code each fall only once, and if the patient has had multiple injuries within a single fall, you're going to code to the highest level of the injury. So an injury related to a fall, and the definition of this is any documented injury that occurred as a result of or was recognized within a short period of time, hours or a few days after the fall, and was attributed to the fall. Now the updated section of this portion of the manual also there's a definition of no injury, which is kind of interesting. So you have both definitions to work with. Injury related to a fall, so examples of injuries that are not major injuries, things that we probably see, unfortunately, skin tears or abrasions, maybe a laceration, bruises, hematomas, a sprain potentially, or any fall that, the patient says later in the day, my back is sore, or I'm just not as comfortable, pain. Examples of major injury, are broken bones, joint dislocations, clearly any head injuries, subdural hematomas, those kinds of things are considered major injuries. Prior surgery is also part of Section J, and there is some adjustments in the manual related to this. There's a slightly clearer definition of what major surgery is, or prior surgery, which is helpful. Again, I think questions came through in the help desk and felt that clearer definition of this would be helpful. But what we're asking here is on admission, if the patient had major surgery during the 100 days prior to the admission. And you code no if they did not, and code yes if they did. Again, for us, we begin attempting to collect that information as part of our pre-admission, but that doesn't always happen, and so then we continue to follow up with that after the patient arrives with us. Usually prior surgery is not as big of a deal for folks who have been in our health system. We have an electronic medical record that is used in the main hospital, and so we can see what's happened to them in the last 100 days. We also have several large medical centers near us that also use the same electronic medical record, and there is an opportunity to have, if the patient allows, what's called Care Everywhere, and so we can look into that patient's record that was at another hospital if they agree to have that happen, and we can look up that information as well. And that's helpful because sometimes patients can't remember or can't tell you. So the definition, the upgrade of the definition is that so major surgery refers to a procedure that a patient was in an inpatient acute care hospital for at least 1 day in the 100 days prior to admission to the IRF, or the patient had general anesthesia for the procedure, or the surgery carried some degree of risk to the patient, life, or potential for severe disability. So if you go to page 53 on the change table, this new expanded definition is available to you, and that can help you identify whether it's a major surgery or not. So let's do a practice scenario here. When reviewing Mrs. T's medical records to identify any falls that occurred during the IRF stay, the reviewer finds one note indicating that during the last 5 days of her IRF stay, Mrs. T was asked to stand on one leg and challenge her balance. Mrs. T leaned to the left, requiring the therapist to provide support to Mrs. T to maintain her standing balance. So how would you code J1800, any falls since admission? Would you say that she is a 0, she did not have a fall, or would you code her as a 1, that she did have a fall? Okay, it looks like people are pretty sure, and they are. And the correct answer is 0. And let's look at the rationale. And in this particular circumstance, even though she sort of changed levels and everything and was caught, intercepted fall, it was because Mrs. T was participating in a session where balance was being challenged. And in order to improve her mobility, challenging the patient's balance was part of her treatment plan. So we expected that she might have that, and the therapist was anticipating that. So that's a little different. Let's try a different one. And in this case, Mrs. G was working on stair training with the physical therapist. While Mrs. G was descending the stairs, her left knee gave out, requiring her to be lowered to the bottom step by the therapist. Unfortunately, Mrs. G sustained a small superficial bruise on her elbow when she bumped it, and she was lowered down. So for the first part of this question, how would you code J1800, any fall since admission? A 0 would mean no, she has no falls, or a 1 would mean yes, she had a fall. See, you guys, despite it being late in the day, on the second day, you're doing real good. And the answer in this case would be a code 1 and yes. And that's because the patient was lowered to the bottom step by the therapist, and that was an unintentional change in position. And she came to rest on a lower surface, and therefore it's considered a fall. We weren't expecting her to do that. Luckily, the therapist was quick and prevented anything horrible from happening, but this was an unintentional change in position. So continuing to move forward on this, so how would we code J1900 based on this scenario? So the number of falls since admission, so would we code J190A as no injury as a 1, code J1900B as a injury except major as a 1, or would we code J1900C major injury as a 2 or more? All right, looking good. That's right. And the correct response is B. She had 1 injury, and it was not a major injury. So that's the rationale here is, again, she did have 1 fall, and it was a minor injury, so it's B1 because she did get a bruise on her elbow. Okay, section K, swallowing and nutritional status. I know, hang in there. K0110, coding instructions. We're going to check all that apply, and this is on admission. You can check more than one category, as I said, and it's important that you include all the correct information. So we know diminished nutritional and hydration has a huge effect on our patients, right? We talked about skin issues on the first day, and those folks who have been in a hospital for a long period of time, have been in bed in some circumstances. So nutrition is huge. Alterations in the ability to chew can also result in choking or aspiration. We see that with a lot of our Parkinson's patients and our MS patients. Increased risk for malnutrition, dehydration, and aspiration pneumonia. One of the things that we did recently too for dehydration is we get, as I mentioned, we have a lot of stroke patients, we have a lot of brain injury patients, we have a lot of thickened liquid patients, patients on nectar thick, some on puree thick. And we struggled with keeping them hydrated. And we thought we were doing a really good job. We would do INOs and we'd keep track, and we would keep track that we are not giving enough fluids. So what we started to do was really identify with the nutritionist, how much do they need, break it up during the day, and then assign people responsible for helping that to happen. So if a patient is in physical therapy, we ask the physical therapist to get 100 cc's of liquid into them at the end of their session. Or if we're asking the team to help participate in getting us and meeting the goal rather than recording what we know is not working, identify what we need to get in, and then work as a team to try to hydrate them. And it's been helpful. We have a really great group of therapists, obviously, right? If they're willing to do that. But it's really been helpful and prevented a number of patients not having to be transferred out for dehydration and issues related to that. Or, you know, you hate to stick an IV in somebody if we had pulled together and been able to get the amount into them. So. Steps for assessment, you want to ask the patient if whether he or she had any difficulty swallowing. Not all the patients come in where they were acknowledged as a swallowing problem. I don't know if you guys see that. Sometimes we get people on a regular diet, thin liquids, they're with us a day. You know, one of the nurses or the CNA says they're coughing on liquids, and we quickly will identify that they had a swallowing issue. So we want to observe them during meals. We're going to look in the medical record, see what nursing, physician, dietitian, clearly our speech language pathologists play a huge role here, and again, we have a wonderful group of people, and any information about swallowing, and then dental history, right? So we're talking about swallowing, but we're also talking about chewing and swallowing. So some of our patients need to be on a modified diet because of their ability or inability to chew. If they don't have their dentures with them, their dentures don't fit, so they may be on a modified diet just because of that component. Section O, special treatments, procedures, and programs. So we're very close to being done. So the influenza season, I love this slide, and when it first came up, I read it 3 times and then realized I was reading it correctly. The influenza season begins July 1st and ends June 30th. Of the following year. So basically what we're saying is that the influenza season is all year long, right? That's what we're saying. So, and I really hadn't thought about it that way, but that's true. There's also the influenza vaccination season that I think we're all more familiar with, and that is, it begins in October and runs through March. I don't know, I'm from Connecticut. We are still ordering Tamiflu. We have patients who are still coming in with active flu. We've had hundreds of patients admitted. This is one of the most devastating flu seasons we've seen in Connecticut. We lost 2 children this year to flu in Connecticut. And so we are still offering the flu vaccine and plan to until our infectious disease people tell us to stop, because we're still seeing active cases of flu. And I know I work with a group up at Weldon, and in Massachusetts they also had it. I don't know if in the rest of the country it was as devastating, but it was a big surprise to us. So here's what the IRF-PAI looks like for or O0250 influenza vaccine. For those of us who do this, we recognize this. We want to record this and make sure that we get the dates correct. And kudos again to our friend over here at the table who spearheads that in his facility. A couple years ago, I told this story at one of the other trainings. My 85-year-old mother, who is very independent. I live in Connecticut, she takes the train into Harlem to visit my brother by herself. She's actually flying to Charlotte to a wedding today, but she's on top of her health care diligently. But one year I didn't check in with her and she did not get the flu shot. She had planned to, she had a cold, and so she put it off. And she came down with a very significant case of the flu. It hit on December 23rd. And so she lost Christmas that year with her grandkids because she was isolated at home. I ended up staying at her little house with her for a week and taking care of her. But, you know, at 85, every holiday, every opportunity to see your grandkids, so get the flu shot. I always remind people that. So thank you very much. I can't thank you guys enough. You've been so kind and appreciate your attention up to this point.